the diagnosis of incomplete Kawasaki disease was kept. An inflammatory markers which was sent showed neutrophilic lymphocytosis and neutrophilic leukocytosis along with thrombocytosis and elevated ESR and CRP. Baseline echocardiographic findings showed moderate side aneurysm in left main coronary and giant coronary aneurysm in right coronary artery and left anterior descending artery. So CT angiography was also done during the acute phase, which showed pan-coronary aneurysms and dilatations, along with a thrombus, which was partial in the RCA, occluding the lumen of the RCA. And these were the dimensions which were noticed, which were quite similar to the echo findings at the baseline. So during the admission, the child was managed with IVIG along with infliximab steroids and cyclosporine as a primary intensification. And for the giant coronary aneurysm, the patient was started on aspirin, enoxaparin, and atorvastatin. On follow-up, the steroids and cyclosporine were slowly tapered over 6 weeks. However, aspirin and atorvastatin was continued, and the LMWH was converted to warfarin with a target of INR between 1.5 to 2. And the follow-up echo findings show regression of coronary artery aneurysms in LMCA to the normalization, and RCA also, the aneurysm has regressed from the giant to moderate size, whereas LAD has persistent giant coronary aneurysms. So in follow-up in Jan 2025, he also underwent MR coronary angiography, which showed large size aneurysms in the LAD, and I also underwent perfusion MRI, which showed normal perfusion, but he had a small subendocardial infarction in the right inferior wall. So follow-up plan is to repeat a CT coronary angiography after 2 years of diagnosis, and to continue aspirin, warfarin, and atorvastatin as of now. And we have concluded from this cases that CTC is essential for detailed coronary artery abnormalities assessment with its complications such as thrombosis during the acute phase, which can be missed in the 2D echocardiography, and the role of MR coronary angiography for identifying infarcts and myocardial functional assessment. I would like to thank my faculty members, residents, and PhD students and staff of Pediatric Immunology Unit and Dr. Manful Singh for providing us with the images for this GAN conference. Thank you.
So how frequently do you do the echo in this child?
So, ma'am, during acute phase, we have done at day 1. Then after the intensification therapy, then in the we have done it 6 weeks. Then 3 monthly, ma'am. We are doing.
And you are given the IVIG, the infliximab, and the steroids all together, like
IVIG, cyclosporin, and steroids all together. We have given, ma'am.
this child did not receive
Infliximab also given, ma'am.
and you stop the cyclosporine
And
steroids.
steroids were tapered off over 3 weeks, and cyclosporin over 6 weeks, ma'am.
Message you want to give us?
So, sir, for acute, the importance of acute CTCA in these cases, such as he had giant coronary aneurysms along with the partial thrombus, and we have seen in the previous study which was done in China that 60% of the patients with giant coronary aneurysm have risk of thrombus formation in the acute phase. So to identify those patients, and to the role of statins and prolonged anticoagulation therapy in these patients, requirement of and also to look for any evidence, and if we know that the patient is having thrombus, so further we can plan for MR coronary angiography to look for functional assessment as well in these patients, sir.
Is the incidence of thrombus-free giant aneurysm?
Sorry, sir.
Incidence of thrombus-free giant aneurysm.
So, sir, in the Japanese study, they have observed out of 144 patients, only around 10% to 12% have developed giant coronary aneurysm, but they have not mentioned about the exact incidence or prevalence of the free giant coronary aneurysm free from the thrombus.
The next speaker is Dr. Soumyadeep.
So my topic of discussion is a case of giant coronary aneurysm in a case of Kawasaki disease who did not respond despite adequate anti-inflammatory therapy. The child presented at the age of 1 year of age, who is a resident of the state of Bihar. The history dates back to March 2022, in which he developed a high-grade fever for a duration of 19 days, for which he received multiple antibiotics. He had a reddish discoloration of tongue, maculopapular rashes, irritability, as well as the reddish discoloration of eyes. However, no evidence of arthritis, cough or coryza was present. He also had a colitis-like symptom, loose stool for a period of 5 days and 8 to 10 times per day. However, no history of dysentery or vomiting was present. Now, at this time, he was treated with multiple IV and oral antibiotic but showed no response. The patient was diagnosed as a case of Kawasaki disease in Har Gangaram Hospital in Delhi. Now, at presentation, the child was anthropometrically normal but was febrile. After diagnosis, they did a echocardiography which showed a giant aneurysm in LAD as well as a presence of clot in LAD. The RCA and LMCA also showed a moderate aneurysm. They started IVIG at 2 gram per kg along with prednisolone, infliximab and cyclosporin. Aspirin as well as enoxaparin were also given. Now, however, despite the anti-inflammatory therapy, the LAD and RCA showed a progressive aneurysm and the size of the clots also started increasing. For this reason, he was referred to our institute. Despite the increasing in the size of the LAD or the RCA, the inflammatory markers were normal. The ESR was raised due to the IVIG therapy. However, the CRP at that time was 0.2 and the evidence of thrombocytosis was there, but other inflammatory markers were normal. Now, after coming to our institute, we did a CTCA which showed a 3 discontinuous aneurysm involving the RCA with partial thrombosis of the distal RCA. A fusiform aneurysm was present in LMCA. A thrombosed giant aneurysm in the proximal LAD was present along with collaterals. The LV apex showed a pseudoaneurysm which may be due to the thrombosed LAD. These are the images of the multiple aneurysms involving the RCA and the LAD. Now, these are the images of the clot which is present in the LAD as well as some collaterals that are present. These are the arrows are showing the collaterals that are present because of the thrombosed LAD. Now, the RCA showed 3 fusiform dilation which are shown in this image. The LV due to the infarction had resulted in a LV aneurysm in the CTCA. Now, this is not the first time. However, multiple cases like this are reported. This is a case in which an infant was diagnosed as a case of Kawasaki disease. After anti-inflammatory therapy, still had a progressive aneurysm. Here, it is a review of literature that is published in Frontiers of Pediatrics. Also showed that in the infancy, although the fever and the inflammatory parameters show a convalescence, the echocardiography is needed to monitor for the cardiac changes. So, despite adequate inflammatory therapy, the coronary aneurysm can progress, and coronary aneurysm can progress even if the inflammatory markers are normal. Thank you.
So how did the CT coronary angio contribute to this case?
Ma'am, the echocardiography revealed the increasing sizes of the coronary artery. However, the rupture of the LV apex, which resulted in a fusiform dilation of the LV apex, was revealed only by the UT coronary angiography.
So what management change was done after that?
Ma'am, after that, we have started the beta blockers. We have started beta blockers, propranolol and carvedilol. Along with that, we have restricted the activities of the child. No contact sports have been allotted to the child, and the father and mother have been counseled. No stressful exercises to be avoided for the child.
Have you done any follow-up on this?
Yes,
child?
yes, ma'am. Yes, ma'am. Ma'am, the child has been planned for a CTC after 1 year, and the stress test and her perfusion studies have been planned, ma'am.
What is new in your case?
Sir, as we follow up a patient of Kawasaki disease, we look for the inflammatory markers and the echocardiography. This case emphasizes the point that the cardiac involvement can progress even after the normalization of the inflammatory markers. Thank you, sir.
Next speaker is Dr. Radhika.
Good evening, everyone. I am Radhika, and I'll be presenting a case which I encountered during my MD. He was an 8-year-old boy hailing from Rajpura, Punjab, a fully immunized, developmentally normal child who has not had any illnesses pre-morbidly to this presentation. He presented with complaints of fever, which was a high-grade fever spiking up to 102 degree Fahrenheit, lasting for up to 8 days. It was continuous in nature and not responding much to oral antipyretic agents. On day 2 of the fever, the mother noted that there was a swelling on the right side of his neck. By day 3 of this fever, he started to develop vomiting and abdominal pain, and there was an episode of passing pale colored stool. However, the color of urine was not noted by the parents. By day 4 of the high-grade fever, he developed redness of both his eyes. However, no discharge was noted. By day 8 of illness, he presented to the hospital near his home, and there he was noted to have strawberry tongue, a maculopapular rash all over the body, and bilateral pedal edema. The management for this illness, so from the day 1 to day 4 of the high-grade fever, he just received home-based oral antipyretic agents. By day 4 of illness, he had visited his local hospital, and there, in view of him passing pale-colored stools, which was preceded by vomiting and abdominal pain, he underwent a few basic blood work, which revealed conjugated hyperbilirubinemia and transaminitis. So, acute viral hepatitis was suspected. However, his fever kept persisting. By day 9 of illness, he was referred from this local hospital to another government hospital this time, which was in Chandigarh. Here he was diagnosed to have Kawasaki disease, and his blood work was done, which revealed leukocytosis to the tunes of 27,000, 22,000. His platelets, which were rising subsequently from day 9 to day 11 of fever, peaking at 8 lakhs. Total bilirubin maximum documented up to 4.6 with conjugated fraction of 3.8. His liver enzymes were elevated to the tunes of 89 and 71. Extreme elevation in the inflammatory markers with a CRP of 290 and an ESR of 70. Suspecting Kawasaki disease with the clinical signs and symptoms, he received IVIG on day 9 of the fever, and an echo was also done on day 9. This was the echo which in the outside hospital, which showed a dilatation of the left anterior descending, and he was however he was there for 2 days, but the fever still kept persisting, and he was given a dose of intravenous steroids and referred to PGI. Here he presented to us on day 12 of his high-grade fever. At this time, the child was kept as a case of IVIG-resistant Kawasaki disease with a coronary artery dilatation, and we did basic investigations. Again, he had leukocytosis with platelets now increased to the tune of 11 lakhs. His sodium was on the lower limit of normal, 133. His liver enzymes had increased to 92 and 112, but by the time he presented to us, his conjugated hyperbilirubinemia has started subsiding, and CRP was 152. In our hospital, he received 2 more doses of intravenous corticosteroids, and treatment intensification was also done with infliximab and cyclosporin. When we repeated an echo for this child, it revealed moderate-sized aneurysms in LAD, LCX, and RCA. So pan-coronary aneurysms had developed by the time of day 12 of the high-grade fever. And we also did an ultrasound of the abdomen, which showed that his gallbladder was partially distended. And since he had developed moderate-sized aneurysms, we initiated him on aspirin, atorvastatin, and low molecular weight heparin. We also did a CTCA in the acute phase for this child, which revealed very clearly that this is the aorta showing very beautifully that there is enlargement of pan-coronary enlargement is noted. In the left coronary artery, there was an aneurysm at the bifurcation, which was 5.4 into 6.7 mm in size. Left anterior descending artery also showed fusiform dilatations, 2 of them. Then in his left circumflex artery, here we can see that it was fusiformly dilated with a maximum diameter of 5.7 mm. Right coronary artery had multiple discontinuous aneurysms, of which the maximum was 7.8 mm in caliber for a length of almost 5 mm. However, there was no evidence of thrombosis. After this CTCA and treatment intensification, the child was discharged. He had become afebrile. On subsequent follow-up, day 20 of illness, desquamation was noted in the periungual regions, and his echoes that we performed on follow-up were as follows: at 2 weeks, 6 weeks, 2 months, 6 months, and 9 months, which showed that there is some regression in the size of the coronary aneurysms. And regarding his therapy, his steroids were gradually tapered and stopped, and low molecular weight heparin was switched to oral warfarin. A quick brush through the literature search on this. So as we know, Kawasaki disease is the most common acute vasculitis in childhood. It is heralded by a prodromal phase. It can have complete, incomplete, or atypical presentations. Usually GI involvement is noted sometimes, but it is not as a part of the criteria. And upon doing a literature search, I found that febrile cholestatic jaundice is one of the main forms of the GI presentation. And usually we'll note the gallbladder ultrasound abnormalities. So owing to this atypical presentation, as in our case, the diagnosis usually gets a bit delayed. And this increases the likelihood of developing coronary artery complications subsequently, and increases the morbidity as well as the mortality for patients. So we should consider the intensification of therapy in cases of atypical KD, and the giant aneurysms usually managed conservatively, and of course the long-term follow-up in such cases is mandatory. Thank you.
Do you know anything specific for the hepatic manifestation?
Ma'am, actually the child presented to us on day 12 of his high-grade fever. By that time, the conjugated hyperbilirubinemia had already started becoming normal. Like we have one record of his LFTs, which was normal total bilirubin and conjugated. And subsequently, as he became afebrile, the transaminitis also improved. So we didn't target any specific therapy towards that.
Did you do any viral markers for this patient?
Yes, ma'am. In order to keep the slides concise, I have not mentioned, but in the outside hospital, he did, since they suspected acute viral hepatitis at the outset, they sent the viral markers, which were found to be negative. And since the fever was still persisting, that was the reason they referred the child to the government hospital.
Is there anything new in your case?
The novelty is just that we don't commonly see this kind of a GI onset illness, and usually we will confuse it for being more of an acute viral hepatitis, since that is more common. And if we do an ultrasound abdomen, in some cases we do see hydrops of the gallbladder, which in this case was also possibly the cause for that conjugated hyperbilirubinemia. And since we will not suspect KD at the outset, the diagnosis will get delayed and hence more morbidity for our patients.
Next speaker is Dr. Yamini.
Very good afternoon. I'll be presenting 3 cases of Kawasaki disease with coronary artery aneurysms and their subsequent follow-up with CTCA. So, as you know, the Kawasaki disease is a medium vessel vasculitis of unknown etiology, and combination of IVIG and immunosuppressive therapy have dramatically reduced the incidence of coronary artery aneurysm. 0.13 to 0.82% of patients still suffer from CAs with varying sizes. So CAs sometimes dilate rapidly in the, as we know that CAs dilate rapidly in the acute phase of KD, but the progressive dilatation and new aneurysm formation in the remote phase is a rare phenomena. So I'll be discussing this aspect. So with this background, I'll start with my first case. Master R, his 13-year-old boy, was diagnosed as a case of complete Kawasaki disease at the age of 5 years. Sorry for the font, I think it has changed now. So the investigations at the presentation, he had thrombocytosis, he has raised inflammatory parameters, and the 2D echocardiogram at the baseline was suggestive of a small aneurysm of LCA. So this was the CTCA which was done at 5 years of age in the year 2017, which was suggestive of dilatation of LCA with 3.7 mm size, and there was a distal RCA medium-sized aneurysm plus 9.09 Z-score, and LCX was also dilated. So when we did a follow-up CTCA at 10 years of age, in the year 2022, we found that the distal RCA measured, the size has increased from 5.2 to 7.2 mm, and the aneurysm which was seen in LC and LCX have regressed. So this was the comparison. In year 2017, the RCA aneurysm measured 5.8 mm, whereas in 2022 in follow-up CTCA, the RCA aneurysm has increased to 7.2 mm. So this is case 2. A Master S, 15-year-old boy, was diagnosed as a case of complete Kawasaki disease at the age of 4 years. His investigation at the baseline was suggestive of increased inflammatory parameters, and the 2D echocardiogram which was done at the diagnosis was suggestive of a giant coronary aneurysm in LMCA and a medium-sized aneurysm in LADA and a dilatation in RCA. So the CTCA which was done at 4 years of age in the year 2015 showed aneurysm dilatation in distal LCA and proximal LAD with a width of 4.5 mm and length of 7.8 mm. So, but when we repeated his CTCA at the age of 11 years, in year 2022, we were surprised to see that we had a new dilatation of RCA, and the aneurysm which was initially in LAD also increased in width and length. So case 3, his Master H, 10 years old boy, was diagnosed as a case of incomplete Kawasaki disease at the age of 6 years, had raised inflammatory parameters, and his baseline 2D echocardiogram was suggestive of giant coronary aneurysm in LAD, and a giant coronary aneurysm in LCX, and a medium aneurysm in RCA. The CT coronary angiography in the year 2021 at the age of 6 years was suggestive of 3 discontinuous fusiform aneurysm in the proximal and mid segment of RCA, and there was a proximal fusiform aneurysm in LAD, and again a giant fusiform aneurysm in LCX. So when we repeated the CT coronary angiogram in year 2024 at the age of 11 years, the fusiform aneurysm in the RCA have regressed. Initially there were 3 fusiform aneurysm, but now we had only 2, and also the diameter has decreased. The LCX giant aneurysm has regressed to only small dilatation, but the proximal LAD continues to be same, and it was increased in size. So this is a comparison of my 3 cases. In case 1, the initial CTCA showed right coronary artery aneurysm measuring 5.8 mm. In 2022, the right coronary aneurysm increased to size 7.2 mm. For the case 2, the fusiform aneurysm in LAD, which was 4.5 into 7.8 mm, increased to 5 into 10 mm, and a new distal RCA dilatation was noticed. And for the case 3, the proximal LAD fusiform aneurysm increased in size. So I would like to quote this paper, which was published in 2005 by Professor Suda et al. And it was a huge series of patients which was published. In it, 562 patients were studied, in which 17 new dilated or expanded lesions were found in 15 patients. That is 3% of the patients. And the time of detection of new aneurysm after KD ranged from 1.9 to 19.2 years, with 4 years. 13 vessels in which previous aneurysms had. All new aneurysms were associated with the low, but in our cases we didn't find any low. 2 expanding aneurysm was seen, one from 19.5 over 17 years and 10 to 15 mm in 1 year. So this is a second in Journal of Cardiology in 2021, where a 33-year-old pregnant woman with a history of giant coronary artery aneurysm secondary to KD had a progressive dilatation of her RC aneurysm from 7.5 to 25 mm at 30 years of age. So what peculiar was that in this, they studied the pathology of the coronary artery aneurysm. Here we can see that the internal elastic lamina was disintegrated and a lot of smooth muscle cells were seen and a neovascularization was seen. And this was different from the typical aneurysm which we see in KD. So the different features in this case from those seen in typical coronary arteries were, there was no evidence of luminal calcification and fibrotic change of the internal elastic lamina, thickening of the media with degeneration characterized by an irregular smooth muscle rich layer in conjugation with partially fragmented IL, and acidic mucopolysaccharide deposition around the new vessels. So I would like to conclude with that. The enlargement of a coronary aneurysm after the acute phase in KD is an extremely rare phenomena, and these patients should be followed more closely. Mechanism underlying the development of new aneurysm in the late phase are unclear. Possible causes can be growth of the coronary artery with somatic growth, abnormalities of the coronary artery wall, hemodynamic factors, and role of CTCA in detailed visualization of the coronary artery. Thank you.
So you mentioned one of the possible causes is growth of the coronary artery.
The somatic growth.
What about the Z-scores in these cases? You have mentioned absolute dimensions. So in a 5-year follow-up, these children must have grown in weight and height. So what about, of course, the aneurysm particularly may not be able to give a Z-score in an absolute dimension. What could be others?
In the first case, which I've shown, the RCA aneurysm, the absolute dimension increased from 5.5 to 7.5. However, the Z-score didn't increase much. But so this can be a possible cause for that, the increasing somatic growth of the coronary arteries. Because the data on this is very scarce, and only I could find few case reports only. The data was very scarce for these kind of presentations.
Do you have any hypothetical suggestion or true suggestions how they can be prevented?
How they can be prevented? I think, sir, what I would suggest would be a timely intensification and more intensification of the treatment, because in one of our cases, the child didn't receive primary intensification. So maybe intensification of the treatment may have decreased the incidence.
Intensification of treatment, acute phase, chronic phase, and which phase?
In acute phase, sir.
And how can we prevent chronic phase?
Sir, so it's a hypothetical, sir. We don't know the cause behind the.
Thank you.
Thank you, sir.
For the last session of the day, I would like to request Professor Surjit Singh to chair the session.